Good to go, ma'am.
Akash sir, we are live now, so you can you can start, sir.
Ashok sir.
Yeah, good evening, everybody. So, welcome to the second session of the GLAD, and this is the GLAD means Gastroenterology and Liver Academy Discussion Forum. So, this has been started by a like-minded peoples across the country, where the main theme is to empower the nation with the primary gastro-liver care. So, with this, we are going to address the most commonly important gastroenterology and hepatology related issues in a basic manner, so that those peoples who have an interest to learn gastroenterology hepatology, not being a specialist, but can give primary care in relation to gastroenterology and hepatology, will be empowered. And this will go every monthly as 4th Friday, 8:30 p.m. And we are going to address one important topics is time. And here there will be a interactive lecture by an expert in this field. Then followed by will you have a case scenario, and this case scenario will be on common topics, the common cases. We just need a little bit of robust thinking to manage at the primary care level. And after this, we'll have a discussion by our esteemed panels. We'll have an invited expert in this field. And at the same time, being virtual also, we have a parallel meeting going on at the regional levels. Today we have joined by 8 centers in a hybrid mode, where our regional moderators are also there. They will do the discussions, and at the same time they will make this to be trained to the local peoples as a part of this academic fiesta. And after this, we will have a robust editorial board, which is chaired by Professor Vaikit Chawla. And in the editorial board, we have Dr. Akash Roy, Dr. Mitra Prasad, Dr. Girish Kumar Pati, Dr. Hemala, Dr. Amna, Dr. Madhumita, Dr. Anand, and Dr. Charles Panak. So they are here, and also we are inviting more and more editors who are interested on this, so that we have plan is now to go for the newsletter. And subsequently, as for the Professor Chawla's interest, we are going to have a case snippets, the case vignettes with the difficult challenge cases, that is particularly for our DM residents, how to do a clinical decision making for the cases. So this will be covered phase wise. And with this, I just want to say that today we have our esteemed panelist, Professor Tarana Gupta. She is from Rohtak PGI. Dr. Rohit Gupta, he has suddenly has some personal issue. He's a professor and head of gastroenterology at AIMS Rishikesh. Dr. Ajay Kumar Patwa, he is associate professor as well as in charge for the gastroenterology unit at KGMU. Dr. Rajiv Lochan, he is our senior consultant and transplant surgeon at Bangalore. Dr. Junaid, he is our hepatologist and gastroenterologist at Lucknow. And Dr. Saurabh, he's a gastroenterologist and a hepatologist, and he's doing all advanced endoscopy interventions at Midas Hospital, Nagpur. So they are our esteemed panelists who will take the discussion way forward. And at the same time, we have 8 hybrid centers, and they are also connected. So this is the whole team. And at the outset, before giving my introductory talk, I want to thank our mentor, Professor Subrata Acharya, and our core members who are the main pillar behind guiding and formulating. Dr. B.D. Goswami is there, Professor Akash Sukla, I think everybody knows him, and Professor Anand S.C. Anand sir, he is also here. And these core members, as the course moderators, they are always here throughout the session. They will guide us. So with this note, I request the session to be carried forward after the due permission from Professor S.C. Anand, who is the senior most faculty, as well as Dr. B.D. Goswami, who is a core member. Sir, please.
I think without wasting any time,
we can straight away go for the case presentation and then start the proceedings straight away.
Sir, we'll go for case or the symposia presentation, sir.
That case presentation.
We'll go for the presentation.
I think better you, Ashok, better you present your presentation first, and just like last time, we can present the case later on, and the panelists can participate. Huh?
Okay.
Is it okay, sir? Anand sir, it's okay?
That is fine. If you want to talk about the GLAD aims and objectives, that also is fine.
Yes, sir. Yeah. So, sir, we are just going to approach to the ascites in general, how to be managed in non-cirrhotic and cirrhotic wise. Then we'll go to the case and then we'll take the discussions. That is usually the plan, sir.
Okay. So, is there a presentation for that?
Yes, sir. I have the presentation, sir. Okay. So with this, we'll go for the presentations. You can. I request that there is a GLAD mail which you have received. In that, please try to have our any communications you can have. So we are going to have a topic is primer of hepatology approach to the ascites. So dear friends, just quickly, not to waste time, I request in between the questions from the audiences can be on the chat box. So we'll go closely to. So ascites, everybody know the definitions. I'm not going to waste. That is presence of fluid in the abdomen, irrespective of any etiology. This ascites can be because of the pressure is on the higher side. There is decrease in the oncotic pressure, or there is excess production of the fluid in the abdomen. And these are the various causes you can see here. So when you go for the ascites, it's common stake that is cirrhosis. But at the same time, not to be having a tubular vision, we need to know the broadly. So all disease can have an effect to do the accumulation of water in your abdomen. Be it liver, heart, malignancy, hypoalbuminemia, vascular causes, or inflammatory conditions. So ascites is not synonymous with cirrhosis, but obviously it is the most common cause for to have a ascites in a patient. So whenever a person comes to you with ascites, we need to consider the liver disease as the first. However, we should have a broad vision to rule out other causes. Hence, we need to know how to go for this patient comes to. So typically, ascites, we need to know three things: detailed history, examination, and investigations. So in a brief, because we are all know about very little bit in detail, but everybody know about the ascites. So whenever a person with ascites comes, we need to know whether it is acute or insidious, because acute can be in case of Burkieri or cardiac causes or malignancy. Is it painful or painless? If it is rapidly filling or slowly filling, how they present, it is the periorbital edema, eye or face, is abdomen, or is lower limb predominantly, disproportionately lower limb edema. So each will give to a clue to the diagnosis. If you consider that there is lower limb is disproportionately more pedal edema, you can think of local vascular or lymphatic causes. If it is having periorbital edema, it may get a clue for the renal causes. This is not sacrosanct, but these are the more common things. If it is rapidly filling, not responding to diuretics, the most commonly we should think of cardiac or Burkieri or malignancy. And then associated systemic symptoms, is it fever, cardiac or respiratory symptoms, also guides you. So in a person coming with ascites, we need to know about this history. That is very much important. Then important comes to the examination. When you go for the examinations, more increase in anteroposterior diameter, that is more in favor of acute onset. If the umbilicus, everybody know they're smiling or weeping or the slit-like, that gives a guide. If it's smiling means it is the more displacement towards the up. If it is slit-like, it is the midline. If it is weeping means it is going down. That means the mass is from the upper. So that will guide us how the direction of umbilicus is going to help. And obviously tenderness is presence, redness or warmth, give some infection or inflammatory causes. Presence of veins no way helps to know the vascular causes. Caput medusae is very much known, portal hypertension. And if any history given by the patient about the color of the fluid, that can give you another clue whether it is chylous, hemorrhagic, bilious, or any other causes are there. Then here you can see if we get a liver is enlarged, if it is tender and pulsatile. So these are the three things on your palpation that will guide that it is something needs to be considered about. Most commonly, the tender pulsatile liver is because of SBOTO, where it is only tender. If it is pulsatile along with the tender or enlarged liver, then likely the cardiac congestion is the cause. So these are the few things we need a clue. Similarly, the veins are here. You have to see the direction of the flow. Everybody know about in the MBBS carriers. Just I want to reinforce this. And also, when you just put your pressure to know the hepatocellular reflux, that can guide also for the vascular causes. So your liver, your neck veins has given a lot of information to the ascites. So then we need to know the ascites grading. Everybody know grade 1 is on investigations, grade 2 visible, and it is simply a septic dullness. Grade 3 is overtly distended or fluid thrill is present. That is the grade 3 we commonly use for the reportings. So everybody aware about the ascites, how to be evaluated. Just to reinforce that, in addition to ascites routine test, we need a thyroid function. We need to know a urinary protein, and also if he is diabetic or any other causes. Ultrasound with Doppler is a must for the basic investigations, and ascitic fluid is need to be considered in all first time presenting with ascites. So everybody aware of about TLC and DLC, definitely. We need to know about the SAG because it is that guides for the diagnosis workup. The protein concentration gives us a clue. ADA is definitely helpful. Cytology we need to consider. Triglyceride depending on the colors, and gene export is used more frequently, but the yield is very less. So I request it to be considered only on a research domain. It may not be helpful. And then with these basic investigations, we can be guided on to the second level of investigations, as you can see here. But here important one thing I want to highlight for all of us, that when you go for this SAG, it should be a paired sample. That means the serum albumin should be sent at the same time as well as the ascitic fluid albumin. And the gap you can delay is 30 minutes. Because in our practice, what we do that we calculate serum albumin from one report, ascitic from one report. So this is not the way to be done. Then ADA should be discouraged if you see that this mostly turbid or frankly looks like a pus, because here the ADA will be high and falsely gives a value that it may be tubercular. Cytology should be considered in a adequate amount, 100 to 300 ml to be sent, so that this can be concentrated in laboratory so that it can be used. And when you send the culture, the most important that the culture should be collected instantly at the point of care and should be given in a blood culture bottle, that is blood agar. It should not be given for the culture routinely. The yield is only 5 to 10% rather than when given by the blood agar is to be 70 to 80%. So these are the few things when you go for the ascites evaluations. When you get a ascitic fluid, everybody aware that what is the diagnosis to be SPP, the most commonly termed when the neutrophil count is more than 250. If it is a hemorrhagic ascites, everybody know about how to do the calculations. Just I want to say that you just calculate for this. If it is a hemorrhagic ascites, you can get the RBC count. Then calculate the PMN by subtracting 1 for 250. So if you are getting 5,000 cells of RBC, then it will be around 20 PMN should be minus. So this is roughly. And the second and most important is the SAG. SAG guides us for the portal hypertension related ascites. So SAG of 1.1 or more should be considered with all the conditions where portal hypertension is there, whether it is pre-hepatic, hepatic or post-hepatic. In all the conditions we can get the SAG should be high. SAG low is considered to be not related to portal hypertension. So it can be number of causes. You can see here, we know it. So the approach should be when you get a SAG should be high or low. That is a basic in school for ascites workup. If it is less than 1, as we have discussed, we should consider a lot of causes, maybe local or systemic. If it is more than 1.1, if albumin and protein is on the lower side, then it mostly because of liver synthetic dysfunction, can be because of cirrhosis or because of the liver volume loss because of the metastasis, or when the body carrier syndrome has progressed to become cirrhotic. If it is ascitic protein is high, that means high SAG, high protein ascites, then we should consider heart failure, body carrier syndrome, IBC, or sinusoidal obstruction syndromes. So these are the conditions we'll get a high protein, high SAG ascites. So dear friends, whenever ascites fluid comes to you, cell count is a must. Hemorrhagic or non-hemorrhagic should be considered. Then we should think in the line of considering ascitic fluid SAG and the protein, and that will make most in conditions will narrow down your diagnosis for the cause. So if we get this, then it will guide for the workups will consider later. So this is in general for a ascites to be considered. As we discussed that ascites is very much common in liver cirrhosis patients, and it is in fact the most common cause, that is around 80% conditions. Will go little bit. Everybody aware of the cirrhosis, how it progresses, compensated, decompensated to end-stage liver disease. The cirrhosis has two components, that is portal hypertension and synthetic function loss. So you can see here, these are the components of cirrhosis related to portal hypertension. These are related to synthetic function. However, ascites comes in both the categories. That is, it is part of this portal hypertension as well as it is part of the ascites also. And it develops in 60% of the cases and has a bearing on the outcome. So if a person with known cirrhosis comes to you with the ascites, this is a three scenarios. That is a new onset ascites, or there is a recently worsening ascites, or it is a refractory ascites which is going on, needs a tapping as a part of end-stage liver disease. So dear friends, you have to categorize a person of ascites, whether it is new, whether it is a recent worsening or is a refractory, because the management will differ according to each group. If it is new onset, if it is worsened from a ascites who is on control on diuretics, or someone is having the end-stage liver ascites. So hence the ascites in cirrhosis can be uncomplicated, as we know. So any person coming with ascites as a uncomplicated, we need to do for the first time a diagnosis of SBP, yes or no. Sometimes we consider total protein for prioritize this group of patients for the SBP, and very often we need to know what is the implications. A person of cirrhosis developing ascites, the mortality at 1 year is 40%, pure mortality is 50%. Hence, this will consider later. This ascites presence, in addition to medical management, needs to be prioritized, that this should be considered for the early transplant. As we discussed, ascites is grade 1 or grade 2. Most commonly, we need first is the treatment is our salt restriction. So salt restriction is considered to be the 4 to 5 grams. So how you calculate? This is your home table, teaspoon. So make it 1/3. So 1/3 of the teaspoon will cover your 1 day's salt intake. This should be advised to your patients. Then we need not to do very low sodium diets, and importantly, bed rest for the prolonged should be avoided, because we heard in lot of clinical practice that you have a liver disease, try to be bedridden. So it is not like that. If it is a cardiac cause, that is something different. Whereas in liver disease, your activity, your mobility improves your ascites as well as general well-being. It also prevents sarcopenia and also prevents the frailty. Then once we have started this, we need to consider diuretics, which are the mainstay of the treatment. In the diuretics, we need a loop and we need a mineral corticoid. So mineral corticoid mostly we are using is spironolactone. The dose can be from 100 to 400 milligrams. And when you consider this furosemide group of drugs, the dose can be increased from 40 to 160. But here I want to say the Indian persons, they most commonly not tolerating more than 100 or 150. They develop very frequently hyperkalemia. And Indian patients also, it's difficult to tolerate a furosemide of 40 or 80 because they frequently develop hyponatremia as well as the AKI. So this definition of dose maximum should be tailored, personalized to be used. Then important here one, when to give diuretics. This diuretic when to be given, we need to consider 3 or 4 things in your mind. This patient should not have actively bleeding. He should not have a AKI. He should not have hepatic encephalopathy. They should not have a hyponatremia of sodium below 120, or they're having hypokalemia of a potassium below 3, and this should be considered to be treated first before starting the diuretics, because this considers to be aggravating the clinical stage. So dear friends, we need to know about hepatic encephalopathy, hyponatremia, hypokalemia, patient having AKI or having actively bleeding. So we very often see that patient having AKI are continuing on the diuretics. So this is the practice to be deferred and should be modified. I hope this session will guide you. Then when you are giving diuretics, they need monitoring of their weight, and this is mostly in a hospital setting. But just want to highlight that if you are giving diuretics, you can sometimes what happens when your diuretic is started, these are not been optimized. So optimization can be done by weight measurement. It is at least 0.5 kg per day if you are having only ascites. If you are a pedal edema, it should be 1 kg per day. And we have to, most importantly, if you are increasing your dose of diuretics, at the same time, we have to monitor their electrolytes and renal parameters also to prevent the electrolyte imbalance, diuretic induced AKI. And albumin infusion is to be considered in patients of cirrhosis with ascites if it is refractory or albumin is needed below, depending on the clinical condition. Mostly we prefer to keep, if serum albumin is below 3, it will be additionally helpful, but that should be depend upon the institute or center practice and the patient affordability too. But if you are going for tapping for a grade 3 ascites, in addition to diuretics has been optimized, we need to give plasma volume expansion. Preferably albumin should be considered. And important clue here I want to give that the standard definition of tapping is as large volume is 5 liters, but this should be optimized from person to person, because more is the sarcopenic, more is the frail patient, more is the advanced liver disease, they are prone to develop paracentesis induced circulatory dysfunction. So 3 to 5 liters to be tapped, and that depends upon your general body conditions and your practical experience as a clinician to do the tapping. However, in a grade 3 ascites with cirrhosis, we need to replace them with albumin, and preferably albumin should be started first and then only tapping should be done. And important here, I want to highlight that these patients are mostly having hypotension. So try to see that this patient should be monitored adequately by parameters. If required, you can give midodrine or toliprecin, that is not be discussing here, to prevent sudden this patient to be deteriorating after getting the tapping done. Then try to avoid NSAIDs. There is most commonly we are using painkillers, that is to be avoided. SC inhibitors or angiotensin inhibitors should be considered to be less preferable. Aminoglycosides acids should be discussed in all cirrhotics irrespective conditions. Then important is comes when the ascites become complicated. It is complicated when it is refractory, if it is having SBP, if it is having hyponatremia or hypokalemia, or these persons are sarcopenic. In this condition, once the ascites develop, the survival drastically goes down. Hence, refractory ascites is considered to be the tapping which is required to be considered, at least not responding to the maximum dose of diuretics. So there's a lot of definitions. I'm not going to do that. And the treatment is LVP. However, TIPS is another consideration that should consider limited group of patients. So a person comes with refractory ascites, we can continue with large volume parenteral with the medical support. This medical support we have already discussed. Newer therapies are coming as like Baptans, tolvaptan is most commonly, and few other drugs has come up. Clonidine has been trusted by PGI. But what I want to say that this group of patients are fragile. The transplant option should be considered at the same time also. Hence, I mark them as the red. If these persons are selectively child B or sodium is below 17, they can be considered for a bridging therapy with a TIPS. However, those patients with ascites should be given the first option of liver transplant, and this transplant option should be early, particularly if the persons are sarcopenic, having hepatic encephalopathy, if having SCC, if they have a portal vein thrombus, they are developing frequently hyponatremia, or they are having poor performance status. So these patients should not be considered for the MELD. They should go for the band MELD exception for the early mobilization of the ascites. If a person comes, the second most important is the SBP. SBP is the most common infection in a cirrhotic. So when you should suspect SBP, any person coming with GI bleed, if he is having shock, fever, or any sign of inflammation is going on, any terms of GI symptoms like pain abdomen, diarrhea, then should be considered. Person of hepatic encephalopathy, or who had suddenly developed worsening of liver and renal functions. So these are the group of patients with you where you should keep a high suspicion of SBP and low threshold for the tapping. Then after that, we need to know that if he is SBP, the survival drastically goes down to less than 1 year. Hence, we consider these patients to be considered for the early transplant. Once a person has developed SBP, nearly 1/5 develop SBP in another time in 1 year. So the chance of having recurrent SBP is high. So this group of ascites patients, particularly cirrhosis, as you know, this is a minimal listing criteria. That is, patients should be transplant should be listed, and this listing is required when child score is more than 7 or child B and C. Presence of GI bleeding, single episode of SBP, refractory ascites, encephalopathy, SCC, liver syndrome. So these are the conditions where there is no live donor option. Even there is cadaver list is there, this should be offered as the listing to be considered. And everybody knows that because of this ASLD or ESL, where live donor concept is poor, they consider the ascites from the beginning should be listed. So we should consider the Indian scenario as per the expertise. Just to conclude my talk, ascites evaluation needs a broad vision, not typical. That is not cirrhosis. We need to know how it is going on. The interesting case will guide us how it is there. Then history examination and a good physical finding is crucial to narrow down the cause of ascites. Cirrhosis is the most common conditions. All ascites for the first time needs a tapping. It should be a clinical practice. Cirrhosis with ascites, if it is new onset or worsening, we need to consider portal vein thrombus, SCC, or worsening of liver failure as the cause. SBP should be considered in high-risk patients. We have discussed the clinical conditions. Early transplant should be considered for those having SBP or refractory ascites. So with this, I think we will open to the questions. And before that, we will go for a case discussion that will be mentored by Professor A.C. Anand.
I think Ashok has summarized all the complexity of ascites in a very short time, and nothing much more needs to be said. I'd just like to add one or two small points, practical points about the diagnosis. The relative importance of pedal edema and ascites should always be considered. For example, what came first? Whether the patient started with pedal edema and then the ascites developed, or the patient first started with ascites and then the pedal edema developed. And similarly, you should also look at the point, which is more dominant symptom. For example, ascites is out of proportional to the pedal edema, then you have entirely different set of causes that need to be considered. And similarly, if the patient presents with only massive pedal edema and just minimal ascites, a different set of causes will need to be considered depending on where the block is. Similarly, if the patient comes only with ascites and no pedal edema at all, probably you'll need to consider peritoneal diseases a little more higher up on the causes. And if the patient has ascites which is associated with fluid accumulation at the other serous cavities, then you should consider entirely different set of causes. So that is a broad way of looking at how to have your broad vision and still localize on the correct diagnosis. Now I think we should go to the case, and I'll ask Dr. Shivam to present the case.
Thank you, sir.
Sir, sorry to interrupt. In that time, I wish the panelists to take the lead for any points to be noted for discussion. Okay, please, Shivam, carry on.
Yes, sir. Good evening, everyone. So before beginning, I would like to specially thank Professor A.C. Anand, sir, for providing me this opportunity. And secondly, before beginning the case, I would like to emphasize that this case was not admitted with us in KIMS. The details were provided to us for presentation. So now beginning with the case, a 56-year-old gentleman, he presented with chief complaints of yellowish discoloration of eyes for 3 months and distension of abdomen for 20 days. History of presenting illness, patient was in usual state of health around 3 months back when he started complaining of yellowish discoloration of eyes which was insidious in onset, progressive, not preceded by any malaise, low-grade fever. There was no history of itching, easy fatigability, or fever with chills. Neither there was any history of waxing and waning, nor any history of passage of clay-colored or silvery stools. Patient also had distension of abdomen, which was insidious in onset, painless, progressive. The distension started in flanks and progressed to whole abdomen over a span of 10 days, for which he visited a local doctor and took some medication, which increased his urine output initially for 2 to 3 days, but symptoms persisted and he experienced no relief. Also, there is history of significant unintentional weight loss, nearly 10 to 12 kgs in last 3 months. Coming to the negative history, there is no history of any pain in abdomen or blood in vomitus, no history of night sweats, evening rise of temperature, no history of altered sleep cycle or altered bowel habits. Neither there was any history of chest pain, breathlessness, decreased urine output, nor any history of cold ill tolerance or facial puffiness or blood in urine. Coming to the past history, patient had history of jaundice 15 years back. He was managed conservatively for that episode, but documents were not available. There is no history of type 2 diabetes, hypertension, or tuberculosis in the past, and repeated blood transfusion in the past with the patient. Coming to the drug history, there was no history of any Ayurvedic medication, complementary or any alternative medication, but there is definitely a positive history of diuretic intake since the patient suggested his urine output increase for initial 2 days. Personal history, patient predominantly takes a mixed diet. Appetite has now reduced significantly for the past 20 days. Bladder bowel functions are normal, and there is no history of tattooing. Patient is a known case of alcohol use disorder for last 28 years, and he daily consumes alcohol nearly 180 to 200 ml, and mostly take whiskey, which corresponds to around 80 grams of alcohol per day, and last alcohol intake was 4 months back. Coming to the summary, 42-year-old gentleman with known case of ethanol use disorder presented with jaundice without any prodrome, cholestasis and cholangitis, and painless progressive ascites with significant weight loss without any history of fever, hepatic encephalopathy, or upper GI bleed. So with this history in mind, we made an initial impression of decompensated cirrhosis of liver with ascites as acute decompensation. But the point I'd like to highlight here, he was having significant weight loss. That was not correlating with our history. He had weight loss of around 10 to 12 kgs in the last 3 months. So that is a cause of concern for us, and we evaluated accordingly. Coming to the general examination, a middle-aged gentleman, mesomorph, was lying comfortably on couch, well oriented to time, place, and person. His initial BMI was 24.2. We corrected the BMI after reduction for ascites, and it came around 21.8. Vitals, his blood pressure was 110 by 70 millimeters mercury in right arm supine position at the level of heart. Pulse rate was 90 beats per minute. Respiratory rate was 22 cycles per minute. He was afebrile at the time of examination and was maintaining saturation at room air. The other significant finding was he was having marked pallor, but surprisingly on examination there was no ictus. Cyanosis was absent, neither there were any palpable lymph nodes, and JVP was not raised. And another important fact is there was no bilateral edema of lower limbs. That is an important highlighting fact here. We had specifically looked for stigmata of chronic liver disease, and patient was found to have spider nevi, palmar erythema, and sparse axillary hairs. But there was no Dupuytren contracture, caput medusae, or testicular atrophy. Neither there was any parotid enlargement, fetor hepaticus, or flapping cramps. Coming to the detailed nutritional assessment, at present, during hospitalization, prior to hospitalization, patient was taking calorie intake of around 1100 kilocalories per day. His mid-arm circumference was 20.4 centimeters, and we did his Royal Free Hospital nutrition prioritizing tool scale examination, and he was belonging to high risk category. We also looked for his muscle strength with the help of dynamometer, and the highest finding was 20 kgs. We also did his physical performance test, that is with gait speed. His 6-minute walk test, his speed was less than 1 meters per second. We can also do 4-minute walk test, and cutoff for that is 0.8, but we did 6-minute walk test. And we did liver frailty index for this patient, and it came around 4.64, and he was belonging to a frail category of patients. After general examination, we did an abdominal examination. On inspection, abdomen was distended, umbilicus was everted, and there was a needle puncture mark in left iliac fossa region, and there was no visible peristalsis, but visible veins were there. On palpation, local temperature was not raised. There was no tenderness. Liver and spleen were non-palpable. We took an abdominal girth. It came around 100 centimeters. And distance from xiphisternum to umbilicus was 26 centimeters. And umbilicus to pubic symphysis was 16 centimeters. Hepatojugular reflex was present but was ill-sustained. And liver span was 14 centimeters. And shifting dullness was present on percussion. On auscultation, no bruit was heard and bowel sounds were present 8 to 10 per minute. Digital rectal examination was normal, within normal limits. And so were the other systemic examination. We could not find any abnormality in respiratory, cardiovascular, or CNS examination. So finally, we made a diagnosis of decompensated cirrhosis of liver with alcohol use disorder. And we proceeded with the investigation. On investigations, hemoglobin was 13.8 grams per deciliter, and platelet counts we were suspecting to be on the lower side, but it were 1.5 lakhs, and MCV was 83.9 femtoliters, and MCH was 28.5 picogram, and MCHC was 34. And his renal parameters were within normal limit. His urea was slightly on the higher side, 49. Creatinine was normal. Sodium and potassium levels were within normal limits, and INR was 1.29. His alpha fetoprotein levels were 3.07. Coming to the liver parameters, his total bilirubin was 2.47 milligrams per deciliter with direct component of 0.73. AST-ALT levels were 35 and 12 respectively. But surprisingly, his protein were on higher side, 9.7, and so was the serum albumin. We were expecting low albumin, but here serum albumin was within normal limits. That was 3.8 grams per deciliter. Globulin levels were raised 5.9, and alkaline phosphatase was normal, and so was his GGT, gamma glutamyl transferase level. Viral markers for hepatitis B, C, and HIV were negative. We did an ascitic tap analysis, and SAG was 1.6, belonged to a high SAG category, and appearance was turbid of fluid. Cell counts were raised, significantly raised, 3600. With lymphocyte predominant type of cells, 75%. Total protein was 5.7. It was high protein ascites, and glucose level were 153. And ADA was significantly raised. It was 104, but malignant cells were negative. We don't have this images for CT, but CT abdomen was suggestive of features of chronic liver disease with omental thickening. And upper GI endoscopy was done for the patient, suggestive of 3 columns of small esophageal varices without any evidence of red color signs. So after doing detailed investigation, we made the final diagnosis of cirrhosis of liver, etiology being ethanol, with portal hypertension, non-bleeder small esophageal varices were there, decompensation with ascites, with sarcopenia and frail category. And patient had malnutrition. Subjective global score assessment was in score B, and mixed ascites was there, that is cirrhosis with tubercular ascites, as ADA levels were quite significantly high, and so were the counts, lymphocyte predominant. He belonged to child 7B category, and MELD sodium levels were 70. So what were the learning points of this case? Firstly, this disproportionate weight loss was, we could not establish with cirrhosis itself with a history of only 3 months. Also on investigation, serum albumin levels were normal. So this is another fact that caused us to suspect there might be some other etiology. And also another learning point here is that all cirrhosis that are presenting with ascites, as Dr. Ashok Chaudhary sir has mentioned earlier, we should go for a detailed ascitic tap analysis. Thank you all for your time and attention.
Thank you, Shivam. So now Dr. Akash Shukla has joined, and Dr. B.D. Goswami, who are the course coordinators. Sir, please guide for the discussion. We have panelists with us, Dr. Saurav Mukhevar and and Dr. Tarana Gupta, Dr. Ajay Kumar Potwa. So these three as panelists, and you two as the post-moderators. I request to proceed for the next sessions, discussions.
Okay. Thank you, Ashok, and thank you, Shivam, for this insightful case. I would like to raise a few things, few issues which I would want comments from the panelists. One is, Ashok has already discussed this, but I want to re-emphasize, when is it that you would consider doing a diagnostic tap in a patient who has come with ascites? Dr. Saurabh, can you take this question up?
Yeah, hi, Akash, nice to see you. Yeah, so question is, when would you do it? Certainly the first timers who present with ascites for the first time would be the ones you need to characterize and identify as to what's the etiology of ascites, number one. In patients with cirrhosis, typically, I would say any patient who ends up requiring admission for cirrhosis should get a tap. I think spontaneous bacterial peritonitis can present in various ways and forms, not your classic abdominal pain and fever all the time. So some can just have renal failure, others can have just pain and discomfort. So I think any patient with cirrhosis who ends up getting admitted, we would typically do a diagnostic tap. And again, I think one thing crucial to understand, I suppose, is if the patient's circulatory status is not clear, we should always start with a diagnostic tap before doing a therapeutic tap, ensure there's no SBP, and then therefore, if it's negative ruled out, then only you can do a more therapeutic tap.
Yeah, thanks, Saurabh. I would agree. In addition, I have certain situations where there is a sudden worsening of the renal function. Patient has an unexplained rise in bilirubin. There is in general, any sudden deterioration in the general condition or any of the specific parameters.
Yeah.
You would think of doing a tap. When the patient comes with fever or patient has abdominal pain in the presence of ascites, you would always want to re-tap these patients. If the abdomen feels warm, I think that is also something which is a clinical experience. So as compared to the rest of the body, then these are the situations where you would consider doing a diagnostic tap. When you're, Dr. Tarana, can you take this question? When you are having
Akash, sir, I have one more addition. So renal parameters are very important. If the patient has a decrease in urine output, or if there's an overt increase in creatinine, then also we have to tap the ascites.
Yeah, I did mention that. That was the first thing which I mentioned. So how do we actually send the sample for the fluid analysis and for the cell count, for the cultures, when you're suspecting SBP?
So, sir, for the first and foremost important thing for diagnosis of spontaneous bacterial peritonitis is to have a cell count. Right, the cell count can be sent even with a very small amount of samples, maybe 2 ml, 4 ml. But for sending the cultures further to identify the organism, the best practice is to take 10 ml of ascitic fluid, and then put it into the blood culture bottle directly. And then you have to send it for the laboratory analysis for the culture purposes. Because ultimately the cultures won't be positive if we send only little amount of samples. So 10 ml, minimum 10 ml should be taken into the blood culture bottles directly. And then gram staining we can perform, but frankly speaking, gram staining is not very fruitful because the yield of bacteria within the ascitic fluid is very low and it has a very low sensitivity, right? And practically we never find it. And even the cultures, they are positive only in 30% of cases. So best way to diagnose SBP is to have a good cell count, and any polymorphonuclear counts more than 250 would be indicative of presence of SBP.
Right. So that's a very useful tip that even a small amount of fluid can be considered for cell count, but for culture you require at least 10 ml to be inoculated bedside into the blood culture bottle. And supposing if your turnover time is late, let's say the fluid is going to be processed after 4 hours, 6 hours, then instead of sending it in a plain bulb, it would be better to send it in an EDTA bulb to preserve the cell morphology and the cell count. So that is another thing which one should keep in mind. If your turnaround time is quick, if it's going to be processed immediately for cell count, then even a plain bulb is good enough.
I think, Akash, you are little slightly confusing this issue. If your looking only for SBP as a diagnosis, then probably what
Yes,
you're saying is right.
as a diagnosis.
But if you are sending a diagnostic ascitic fluid tab, then 2 to 4 ml for the cell count will not be enough. You need
I agree
cytology
completely
sample,
with
you need a much larger sample for that.
Yes, so in fact, if you are sending it for a malignant cells, you actually need to send at least, in fact, as much as possible.
Generally, we send minimum 50 ml.
Maybe
So
Minimum
500
50
ml to 1 liter around we have to send, sir, and we have to centrifuge the sample to concentrate the cells before examination if you are wanting a cytology. So maybe around 500 to 1 liter of fluid has to be sent. And regarding the culture, if we are suspecting SBP, the inoculation has to be bedside. As compared to bedside inoculation versus lab inoculation, there is a 27% increase in yield rate if you inoculate the sample bedside. So around 15 to 20 ml of sample we have to inoculate in the culture bottle.
Yeah, that's right. What I was trying to emphasize was to preserve the cell morphology. If the turnaround time is delayed, then it should be sent in EDTA bulb rather than sending in a plain bulb for the cell count. So that was the point which I wanted to emphasize.
Would you like to ask someone to comment on what this patient had? Did he have SBP or not? Because cell count was high, but
that is an interesting thing. If you count 3,000 cells and if it's 25% neutrophil, then the count is also become more than 250. So is it SBP or it is
you call it SBP or not?
So,
yes,
so SBP you call only in the absence of any other infection. So if you have any other infection like a mycobacterial infection, you cannot diagnose SBP. So that is something which you have to keep in mind.
But a similar percentage you can get if it is partially treated. Suppose
yes.
So it should be neutrophil predominant.
So that brings us to the next point. Now, in a patient who has come to us with, let's say, I'll give you 3 situations. The ascitic fluid cell count is 200 and 100% lymphocytes. The ascitic fluid protein is 0.8. The SAG is 2.1. What would be your diagnosis?
We can label it as SBP because the protein amount is very less, and due to dilutional, there can be a low absolute count. We cannot always go with the 250 criteria.
No, so this patient has 100% lymphocytes. Total count is 200. So this cannot be considered as SBP. So this patient actually, this can be considered as a normal cell count. And very often in diuretics, you can have cell counts up to into this level without any problem. So this patient with 200 cell counts with only lymphocytes cannot be diagnosed as SBP. The diagnosis requires at least 250 polymorphs.
Yes. That too in a neutrophil predominant cell.
Yes, and also do not consider this patient as tuberculous, because although this is 100% lymphocytes, a cell count of less than 250 is usually not suggestive of tuberculosis. For tuberculosis also you require a higher cell count. So very often you will get mildly elevated cell count because of diuretics itself. So this is something which you have to keep in mind.
Sir, there is a few questions in the chat box. Professor Akash Shukla or Professor Anand, you can go through.
Yeah, I'll just read out.
So they're asking how to calculate SAG ratio who is on diuretic therapy. Dr. Mukhewar?
Hi. Yeah, so I think one thing...
How to calculate SAG ratio?
Yeah, I think what Akash Shukla, thanks for pointing that out, I think is that on diuretic therapy, the lymphocytes typically do go up in the fluid. And I've seen patients being mislabeled as tuberculosis because of a predominant lymphocyte count, which is inaccurately labeled as to be from tuberculosis. Now, as far as the serum ascites albumin ratio, globulin ratios, gradient ratio is concerned, I mean, I'm not sure if it significantly changes. That's not something that I'm aware of, but I think it should still be the same, what you would expect in a regular cirrhotic patient. Please correct me if I'm wrong. Yeah.
Yeah,
The SAG
you
ratio
are right.
shouldn't typically change.
You, myself, Dr. Ajay from Lucknow.
Yeah, hi. Thank you.
Yeah, Dr. Sir, you are absolutely right. With diuretic therapy, SAG does not change.
Yeah.
I think Dr. Ashok, would you like to add something else on that?
Yeah.
I think just one little thing I would say is, see, at the end of the day, we are calculating the difference between the serum albumin levels and ascitic fluid albumin levels. So we have to be cognizant of the fact that this is typically raised in portal hypertension or cardiac patients, but provided this patient is not severely malnourished, where your serum albumin levels can be drastically low, I suppose, and then your SAG ratios may not necessarily be at significantly over 1.1, and they can sometimes be borderline. So I just sort of a word in there, but mostly, yeah.
But I think Professor Sakas can guide me. I think the SAG don't change much with the diuretics. I think it is the ascites will remain the same.
So the protein can increase with use of diuretics. So if we are, when we take the criteria of the high SAG and high protein, or high SAG and low protein, so the protein can get concentrated and can be rise in protein, absolute total protein concentration with use of diuretics. But SAG remains.
Vikas is right on that. The total protein may rise, but the albumin, ascitic albumin and serum albumin ratio does not change. Albumin is a very large molecule, and it will only leak into the peritoneal cavity if the permeability has been increased by some peritoneal disease. So, for example, if there is a tuberculosis, or if there is any other infection, or even if there is a malignancy which is involving the peritoneal cavity, then the large amount of albumin will leak out, and the ratio will, the gradient will become less than 1.1, because more albumin would have been released into ascitic fluid. But as long as the peritoneum is normal, the permeability is normal, the albumin doesn't leak out so much. Protein may be high, but albumin will be low.
Yeah. Sir, another thing they're asking about Dr. Ajay, you can say how to manage ascites in diabetes.
In my opinion, management of ascites in diabetes is not much different than non-diabetic, except for that diabetics are prone for renal injury. They have already a little bit or more compromised renal function, so we should take care of that. Number one, and the rest of the things are same.
Here I want to add, I think Dr. Hemala, yeah, because SGLT has any role, SGLT inhibitors, because they have a dual purpose in ascites only, because few studies recently has come that SGLT inhibitors can be helpful for ascites mobilization.
Not that I'm aware of, but regarding as what sir said, Dr. Ajay, that sir, renals are generally compromised in diabetics. So use of ARBs and ACE inhibitors, if we can avoid in patients who are about to develop, or maybe with high caution, we should use these drugs. SGLT inhibitors, definitely they had a role when patient was developing fibrosis. But for ascites with decompensated ascites, whether anything is in the guidelines, sir, I'm not that aware of such.
It is not in guidelines. Coming up, I think Dr. Akash, anything, any suggestion on any?
I'll just add one more point. We should avoid pioglitazone in patients who have ascites, because pioglitazone can cause fluid retention. So that is something which we should keep in mind.
Yeah, that is very important practical.
I would like to add.
Yeah, Dr. Tarana, please.
Yes, SGLT inhibitors, they theoretically, they are on the investigations that they may be very helpful, because they inhibit the sodium glucose co-transporter in the kidney. So they may be helpful in control of diabetes, as well as they may be improving the, reducing the fluids in case of ascites. And plus their third action, that they improve the cardiac functions, and that can be beneficial in cirrhosis. But still there is no clear RCTs available where we can say as they are beneficial, and especially the safety in decompensated cirrhotics, which is essential and which is missing at present. But yes, in future we may have SGLT inhibitors may be there for control of ascites, especially in patients with diabetes.
There is also some concern that they may increase the incidence of urinary tract infections.
Yes, sir, that is a complication. Even in diabetes, this is a adjoining complication with the use of SGLTs, increasing the risk of UTIs.
So that can cause more decompensation in cirrhosis.
Yes.
So
there is also a question in the chat box, how to explain normal GGT here. In fact, there are lots of things which need to be explained because Dr. Ashok Chaudhary has thrown in here and there a lot of interesting points. So anybody would like to answer that?
Normal GGT here just means because cirrhosis have a higher chances of developing tuberculosis, around 1.6 versus 8%, and many times liver is also involved when there is a peritoneal infection. But in the normal GGT in these patients, just we can say that the liver is uninvolved in this case, or maybe we are not dealing with a tuberculosis.
Patient gave a history of very significant amount of alcohol intake for a long time, 80 grams per day.
Sir, but
and there is a history of jaundice for 3 months.
Yeah, so maybe that
so
maybe that was the cause for abstinence and the GGT normalized over time.
Possibly it is the abstinence over last 3 months that has normalized GGT. Yeah. So that is another question.
So that is basically. So GGT in a patient of liver disease, we have to do 3 things. One is alcohol. Maybe he has come to us after 3 months of management, so likely the effect of alcohol has gone off. 2, as rightly said, because if infiltration by any infiltrative liver disease or because of the biliary or hepatobiliary tuberculosis. 3rd is the CAM intake, any complementary medicines. So it is all are not here in this case. So that's why maybe the GGT is going down.
There is another question in the chat box. How to differentiate a patient when it is proceeding towards HCC from cirrhosis with special reference to ascitic fluid analysis. Can anyone take that?
The ascitic fluid analysis, I don't think that there's anything which will differentiate whether the patient has developed HCC or not. Only one thing, if the patient has HCC which is ruptured into the abdomen and causing a hemorrhage, then only we can say that it's a SOL which has ruptured. Otherwise, sir, in ascitic fluid analysis, there not much we can differentiate, sir, whether the patient has a HCC related decompensation or there is a progressive liver disease or the patient has developed a thrombus. What has caused the decompensation? Sir, patient has developed HCC and ascitic fluid examination, we not be able to tell. Maybe on a LFT, a rising GGT and alkaline phosphatase would suggest that the patient is developing an obstruction and an SOL.
Very true. So any rapid deterioration in the liver status or any rapid development of decompensation, one should suspect HCC. But ascitic fluid analysis will only change if the will change only if the peritoneum is involved. Akash, any other thoughts?
No, sir, I agree. Except that one more situation is when the liver is operating, there again you get slightly higher GGT. So that is also one of the, in fact, in such a patient, normal GGT in somebody who has got a very advanced liver disease is actually a poor prognostic marker, because that means the liver is not attempting to regenerate. Whereas when the liver starts regenerating, you actually do see a rise in GGT. So I think that is also something which can be considered as a prognostic marker.
Okay, I think that finishes the chat box questions. Now you can carry on from where you left.
So actually,
sir, one more. Yes, sir. According to this current case, sir, is it justified to think of tuberculosis at any point of time, or only after getting the ascitic fluid we should think of? Are we getting any clinical proof? Suppose in our OPD follow-up, all cirrhotics are also sarcopenic and cachectic. So, what are the soft skills, or can say the clinical clues to suspect the tuberculosis in a patient of cirrhosis?
In fact, I'm quite surprised that nobody has asked this question. You, in your presentation, said that if the ascitic fluid is turbid, the ADA should be disregarded. And now you are asking why are you considering tuberculosis? So anybody?
As a clinical suspicion, sir.
Huh?
Sir,
Anyone would like to answer that?
Sir, when we go back to the case history, sir, this is a patient who had a decompensation and a jaundice, but there was no infection symptoms, there was no bleeding, but the patient developed a decompensation. The symptoms were also insidious. Weight loss was maybe one of the clues, and the patient initially was started on diuretics, with which he responded only for 2 days. So a tuberculous ascites may not respond as likely as the portal hypertensive ascites. So that was one of the clues that we may not be dealing with a portal hypertension related ascites, maybe a mixed ascites or something else we were dealing with, diuretic non-response adequate. And also, sir, because alcohol, one of the risk factors for tuberculosis, sir, first time examination we always had to do. In examination, sir, liver was 14 centimeters. So the size span was almost normal, although the firmness of the liver was not mentioned. And whether a particular lobe was enhanced or not, that was also not mentioned. The spleen size was not mentioned. So we assume that the patient had a normal spleen. I don't know, sir, if I missed. And then, sir, we went on the examination, which said the liver function by and large were conserved. INR except was 1.29, which can be due to jaundice, cholestasis, or maybe malnutrition is also part of alcohol intake. So that was in history, that was the pointer, sir.
I think you've covered everything except one small thing. I mentioned that if, in spite of having moderate ascites, there is no pedal edema at all, that would indicate that disease probably lies in the peritoneal cavity. So if moderate ascites is present, some degree of ankle edema or something would be present if it is just pure and simple decompensated cirrhosis. And you very rightly said that the albumin levels were fairly decent in this case. And then, of course, cell count and ADA has given away the...
And diuretic not response, sir. Directly the patient, that was categorically said only 2 days he responded, and then things stabilized.
Very true, very true.
My question is...
Sir, my suggestion is, sir, whether the role of IGRA or HRCD thorax can help to find out a diagnosis in this case. IGRA test and HRCD thorax, whether they can be aid in some diagnosis.
In this patient, HRCT was normal, but the IGRA was positive. So how you go then?
In addition,
Yeah,
IGRA is positive.
Then ascitic fluid culture should be offered to the patient. If it is positive, then it can be tuberculosis. Ascitic fluid culture for tuberculosis, or PCR for tuberculosis in ascitic fluid. So I feel that can help in arriving at a diagnosis.
in addition, you have shown that CT abdomen showed omental thickening.
There is omental. Are you going to do for go for an
there.
omental biopsy, sir, for this patient, or you'll start tuberculosis drug directly, sir? That's a practical question, sir. I know we don't have a direct diagnosis of tuberculosis. Akash, sir, would we do a peritoneal biopsy for this, sir?
So usually, as far as possible, in our practice, we actually try to obtain omental biopsies, omental or peritoneal biopsies. We would always look for presence of tuberculosis elsewhere as an ancillary marker. And if we do not find, we actually try to do a diagnostic laparoscopy and obtain a biopsy, but that may not be practically possible for everybody. So in those setups where it is not possible, I think it is perfectly acceptable in patients with very high cell counts and predominantly lymphocytes. If it is persistent, probably across 2 tests, it is prudent to go ahead in the presence of high ADA, probably to go ahead with treating as tuberculosis ascites. So I think in the community, it may not be possible to do a diagnostic laparoscopy for everybody. But what I would definitely suggest, like Dr. A.C. Anand sir brought out, that it could be a partially resolving SBP, and that should not be mistaken for tuberculosis. And therefore, you have to prove, at least with 2 cell counts, that it is really persistently high lymphocyte predominant ascites.
So you should give non-tubercular antibiotic. Sir.
So sorry, you said that, whatever you're saying. I just wanted to add one small thing to what
rightly approach that we should give non-tubercular antibiotics. Sorry, sir. Please.
Yes, Akash, would you like to answer that?
Yeah, no, I agree with him that we should be giving non-tubercular antibiotics to these patients. So do not give them levofloxacin or azithromycin. Levofloxacin is one of the commonest drugs which people use, or fluoroquinolones or ciprofloxacin. So those are not the antibiotics we should be giving. We would usually give a cephalosporin to these patients before we repeat the cell count. So something like a cefixime would be good enough.
I just wanted to add to your previous question that you answered about doing a histology for peritoneal biopsies. There is one situation where biopsy would be required. In high prevalence area, I think you can give a therapeutic trial and get away with it. But in low prevalence area, for example, in Europe or in America, if you are going to see a case like this, they will definitely like to have a histology to make sure that they are not missing any malignancy, because that is more common than tuberculosis in their setting.
Yes.
More so in presence of a normal HRCT thorax.
Yes. There is one more question in that.
So that's why in our practice, sir, we would almost always try to obtain histology, even in our setup. But although we are in a high prevalence setup, but we have been fooled many times. But sir, when we are talking to an audience like ours who are practicing in tier 3 cities or tier 4 cities, it may not be practically possible. And therefore, I think what you said is appropriate, that if we can demonstrate it, we should not be fooled by resolving SBP. So if all of the tests are negative, and if at least 2 times, despite adequate antibiotics, the cell count is high and lymphocytic predominant, it will be prudent to consider this as tuberculosis.
I just had a quick comment. In this particular setting, when you had 2000 lymphocytes, now, would it still be possibly a resolving SBP, or could it be diuretics that have led to a lymphocytic predominance? I think it does pose a diagnostic dilemma in the sense that I know the AD is high and some parameters which are off, but when you're subjecting someone to anti-tubercular therapy for 6 months, probably, I think in setting of decomp cirrhosis, I'm always a little apprehensive of giving them 6 months of therapy, unless I'm really certain. I mean, this one does pose a diagnostic challenge here.
So, Dr. Saurabh, to answer your question, I think your point is valid, but the diuretic-induced cell count is rarely above 500, and even in case reports, it has never crossed 1,000. So anything above 1,000 is not diuretic-induced for sure, and there's very little differentiation. So it could still be resolving SBP. That is why we should still repeat an ascitic fluid once more and confirm if it is really lymphocyte predominant, and cell count remains to be the same as it was. So that is when I would say that yes, this is tuberculosis.
Sir, one more question. I think Dr. Hemmala is here. Dr. Hemmala, is diabetics are more chance of having SBP? Can you suggest anything?
I don't think so. It is like that. Right? SBP is more related to the the hepatic function or the child grade of the liver disease. They are prone definitely for cellulitis and other infections, but SBP I'm not really so sure.
And okay, thank you, Dr. Hemmala. I don't. Everyone, I think the same boat, sir. Any difference? Dr. Anand, Dr. Sukla?
No, we agree with that. Only thing is that these patients who have diabetes, they tend to have more likelihood of having refractory ascites. So that is a French multi-center study which has shown that presence of diabetes is associated with refractoriness of ascites. And those who have refractory ascites, they tend to develop SBP more often. So there is an indirect relationship, but there is no direct evidence to connect the two, although it would be logical to.
My understanding is that this SBP is a manifestation of low opsonins in the peritoneal fluid. So normally whenever there is a transmigration of bacteria from the gut, they tend to settle in the ascitic fluid. But if the opsonins are rich, normally they are very quickly removed. But in cirrhosis, the protein levels are very low and opsonins like fibronectin are very low in the peritoneal fluid. and that's why they tend to seed there. So this is what my understanding is, and diabetes may not have much effect on that.
Yeah.
Thank you, sir. And there is another question. This patient having platelet count normal, albumin normal, and protein is high. So is there any underlying MPD? Dr. Mitra Prasad? Dr. Mitra?
Yes, sir. Sir, right here, sir. Sir, yes, so this is another scenario. We had a very similar patient, sir, who seemed to have a chronic liver disease, but not sufficient criteria to term her to be decompensated. All the other parameters seem to be quite nice, and still a high ADA and a predominant ascites, less pedal edema. So again, this will be another scenario where maybe additional testing for to confirm whether the patient is decompensated or not will help prove more towards tuberculosis rather than just pointing everything towards cirrhosis.
Yeah.
Maybe a HVPG and additional testing would definitely help. But again, not in
Dr. Mitra, we are discussing with, as rightly Dr. Akash, we are tier 3 and tier 4 people's.
Tier 4, tier 3 and
SCP
tier
is just
4
not available in tier 1.
Yes, sir. Yes,
So,
sir. Very true. Very true.
So basically, clinical clue.
Probably.
So clinical clue that if the cirrhotics should having. Yeah.
Sorry. Go ahead.
And sir, Anand sir, they are asking about regimen of ATT for these patients. Any guidance from you?
Normally, if there is a chronic liver disease, we usually modify the ATT regime. So if it is a child's A cirrhosis, we give the normal regime 4 drugs. But if it is child B regime, we try to reduce 1 or 2 hepatotoxic drugs. So, for example, the most hepatotoxic, there is some controversy whether it is rifampicin or is it pyrazinamide, but I usually consider pyrazinamide as more hepatotoxic as compared to rifampicin. So rifampicin, INH, ethambutol, and possibly levofloxacin. This will be the regime for child's B case that this patient is. If it is child C case, then we can only give 1 hepatotoxic drug and we give 2 at least non-hepatotoxic drugs. That's the regime we follow.
Akash, is there any duration of ATT to be decided because we modify ATTs? So, how you guide for duration for ascites, tuberculosis ascites in a cirrhotic?
Yeah, so if you are using sidal drugs like the ones which Dr. Anand mentioned, if you're using rifampicin and isoniazid, then probably the standard duration would be adequate. But if you are not able to use sidal drugs, if you're using only 1 sidal drug, then probably you would need to extend the therapy. And usually in that case, we would treat for 12 months to 18 months, depending on whether we are able to use good drugs or not. So typically in child C, if we are not using any bactericidal drugs, not more than 1 bactericidal drugs, then usually we would give for 12 months. That would be our standard protocol. But again, this is what we follow. There will be variations from one center to another. But I think to be on the safer side, anything around 12 months would be adequate in such situations.
Yeah. So basically what in my ILBS, what we are practice that child C, no hepatotoxic drug, child B, single with close monitoring, and child A, you can give the normal regimen. And then as rightly said by sir, you, when there is having any hepatotoxic any sidal drug, then it is at least 2. If it is 1, then direction should be 9 months to 12 hours, for which are normally considered as the 6 months, particularly pulmonary or ascitic. If it is become bone or CNS, the duration extends to 18 months to 2 years. It depends upon the sidal drugs, how much you are using. So it is very confusing. Here, I think what we can suggest for these peoples is they have to see that is child A, B, or C. If child A, they should treat. If child B and C, they should take opinion from a gastroenterologist. I think that will be a good suggestion for this forum, if you are agreed. Sir?
Yeah, I would agree
That should
completely.
be all right. There is one more thing I'd like to mention, that WHO is recommended for extrapulmonary tuberculosis. Earlier, we used to give 4 drugs for first 2 months, that is HRZE, and then 2 drugs for another 4 months. 2 months, 4 drugs, and 4 months, 2 drugs. Now that maintenance dose has now become 3 drugs.
Yeah, 3 drugs.
It is HRE.
Yes.
Rather than just 2 drugs.
So I think we have gone more than 1 hour for this room. Yes.
Sorry to interrupt.
Sorry.
They're not audible at all. Dr. Ajay, please.
Question to Akash sir.
Your Wi-Fi connection.
Yeah, I'm audible.
Yeah, now
Yes.
you're audible. Please.
Not audible.
Audible. I can hear you now.
Dr. Ashok. Oh, I'm sorry.
Hello, am I audible? Hello.
Okay. So
I have one question. I want to have one quick question, that should we continue diuretics?
Can this high level of ADA may be due to any malignancy?
I think can we get the messages in chat box?
Yeah. So I think there's one good question in the chat box. Is there something like a fungal ascites? The answer is we do get fungal SBPs. It is well reported, and these are patients who have had repeated admissions. So it is possible. So in patients who have been treated with appropriate antibiotics and you are still not getting a response, then in those patients, we should send for fungal culture as well. And these are the ones where you will get, again, a high lymphocyte count. So I think that's a valid point. But again, it's rare. I don't see it very frequently, but definitely possible.
Yes, so in 138 patients of SBP, which was in my thesis, sir, we had taken culture of all patients. Only 1 patient was a fungal candida infection.
Yeah, it is known.
Doctor, am I audible? Hello?
Yeah, audible.
Yeah. So we have one question, that should we continue diuretics in case of refractory ascites? And what is the, if yes, then what are the medicine and what is the duration of that, duration and dosing?
Dr. Saurabh, can you?
I think by definition, when you're talking about refractory ascites, it means that the patients are refractory to diuretic therapy. I would imagine that's what you mean. And then I think in these cases, you'll have to undergo serial paracentesis, or TIPS probably are some of the options in terms of management in these patients.
So is any
to elaborate on the answer? So I think the question, if I'm understanding correctly, is in a patient who has developed refractory ascites, is there any use of continuing diuretics, because the diuretics obviously not worked, and that is why the ascites is refractory. So that is the logic behind asking the question, if I've understood correctly. So there are two reasons why diuretics or the ascites becomes refractory. One is the maximum dose of diuretics is not working, but that is very rarely the clinical scenario. We rarely reach the maximum dose of diuretics. What is far more common is that we are unable to use the maximum dose of diuretics because the patient develops the side effects of the therapy, like rise in creatinine or electrolyte hyponatremia or other electrolyte imbalances. So if this is the situation, or this is the case, then you would usually use the highest tolerated dose of diuretics, because at that dose, although you may not avoid paracentesis completely, but probably you would still reduce the frequency of the paracentesis that is being required. So I think with that intention, probably you would continue to use. The only situation where you would not use is, despite using diuretics, if the urinary sodium does not increase. Then those are the patients where actually continuing diuretics does not make much sense. You'll only cause side effects. But again, these are for very advanced level of practitioners, those who are seeing these patients every day in and out. I think for our audience, if they're having patients with refractory ascites, those are the patients where a gastroenterology consult should definitely be taken and not just rendered to repeated taps. And also, we should consider alternative therapies for them like TIPS or transplant. All these are options that are available for these patients.
Yeah, I would just add to that one option, obviously one thing to ensure is that these patients are not taking salt, because I think that's one important reason people may not still understand. And I guess the other thing is also midodrine can be an option when you cannot really maximize your diuretic doses. So you can start midodrine and see it seems to work in some patients. Not a phenomenal drug, but yeah. Dr. Shukla, if you have, what are your thoughts on adding midodrine to this patient?
So I agree. So there are options, medical options for refractory ascites as well. So midodrine and toleptan and
so forth,
even clonidine. So all these are options, but I think these are again will be used only in expert hands and people who are using these drugs every day.
Yeah. Okay. Thank you.
Okay, Shivam, you had presented the case. You want to ask any question?
Sir, what can be if albumin is normal and but on upper GI endoscopy there were small varices? So was this ascites, varices due to portal hypertension because of alcoholic hepatitis, or has the liver decompensated that has led to portal hypertension and development of varices?
So if the ascites is due to tuberculosis, would he still be child's B? That is the question I'm going to ask.
So I think, sir, this is a Pandora's box. But interestingly, what I've is my observation, and again, I have not published it, so I'm the culprit. But when such patients, we start them on anti-tubercular therapy, their child score invariably improves if their tuberculosis is responding. So even their liver function improves, their bilirubin tends to come down. And it is probably because of combination of abstinence from alcohol, but also I think they do have some subclinical involvement of tuberculosis involvement of the liver. And as that resolves, the liver function also does tend to improve. And in fact, I've had patients whom we had listed for transplant, and they were eventually taken off the list completely because their liver function improved so much after the anti-tubercular therapy. So, sir, you are right. Giving a child status because of tuberculosis ascites is impossible. I don't think I have an answer to that, or anybody can answer that question. But definitely they do tend to improve once you start them on ATP and hepatitis A.
Ajay from Lucknow, sir. May I add something?
Yes, sir, sure.
Sir, Anand, sir. I'm very junior to you. I met you in Delhi during the midterm INSL in 2014, sir. So perhaps I may not satisfy you, but let me try. Sir, by definition, if the patient had developed ascites, there is high SAG, I would put in class C.
Very good.
Whether pathophysiologically it may be class B, but right now the patient is class C.
Very good.
Yeah, but sir, tuberculosis is known to cause a prehepatic form of portal hypertension. So that's a known cause. So that is specific to this case, sir. Are we dealing with a portal hypertension that is related to cirrhosis related, that is intrahepatic, or is a prehepatic hypertension due to tuberculosis? That was
I just wanted to add an extra.
I think
it is simply a case of.
We should not.
It is mostly a mixed ascites because. Yeah. Yes.
Ashok, I think we should not be confusing our audience. Our message should be loud and clear because our audience is predominantly physicians, we should not give messages which can actually confuse them. So here we should assume, I would agree with Ajay, that if pathophysiologically this may be tuberculosis, ascites, if it is high cell count and high protein. But I think for the convenience of everybody, let us keep it the way we have been doing traditionally so far and stick to that, because there is no evidence to the other side, and follow the regimen depending on the local preferences, especially for child A. I think some, like you use all the drugs, many centers would not use pyrazinamide. So again, ensure that whatever therapy we are giving, anti-tubercular therapy, whether it is in child A, we are giving 2 drugs or 3 drugs, hepatotoxic drugs, the monitoring is extremely important. Their LFTs should be monitored very closely. There should be a low threshold to stop the drug if we find worsening of the liver function. I think second important message which we should give to the audience is that tuberculosis therapy is possible, and if you treat the TB appropriately, most patients will improve clinically, not only from the TB point of view, but from the liver point of view also. And third is patients who are child B or child C cirrhosis. It is best that these patients are managed in consultation with a gastroenterologist, where appropriate monitoring can be done. And once the patient have developed refractory ascites or tense ascites, again, we should look for other options rather than just giving therapy for medical therapy or repeated taps. So I think these are the clear messages which we should give to our physician audience, and that would be my take-home messages.
You can add to that LFT monitoring, generally we recommend every week for first month of ATT, and every 15 days for the second month, and then every month subsequently we should get the LFT checked.
Yes, sir. Completely agree with you, sir. Absolutely.
Okay. I think we have a very nice discussion. We should come to the end. Professor Bedi Goswami sir is there. Professor Goswami sir. Okay. So I think we'll announce the next month will be the GLAD3 session. It will be on 24th of June. That is the same Friday, 8:30 p.m. And the topics will be the varicose bleed in a cirrhosis as a case, but we'll go to the approach to bleed in a case of liver disease in general, but it will be more focused towards a GI bleed management, a person in a primary care setting. So we request everyone to be tuned with this. And by this, we want to close. But before that, Dr. Lalit wants to say something. Please.
I have just a couple of questions for Akash before we just end the meeting. So one important question is, in child C cirrhotics, do we have any data or studies which say that INH rifampicin combinations are toxic, or they're more toxic than other regimens? The question arises because the other drugs which are which can be given in those in whom you cannot give a third drug like pyrazinamide would be again nephrotoxic, and that is something that you also need to avoid in patients who are cirrhotic. So you cannot give streptomycin, for example. So the armamentarium of drugs is less. So is there evidence to say that INH rifampicin is actually a toxic combination in child C cirrhotics?
So thank you, Dr.
It is there evidence.
Yeah, there is good evidence to suggest that the combination of rifampicin and INH is more toxic than each of them, the addition of the two drugs individually. So there is evidence even in the absence of cirrhosis also, and definitely in the presence of cirrhosis, there is evidence that this combination is worse. And therefore, you would use one of the two drugs in patients with advanced decompensated cirrhosis.
But what would be the other drugs that you would use? Say you are using INH.
Yeah, so that I agree with you that
but what else can you use?
aminoglycosides is again a big cause of worry for patients with child C cirrhosis, and therefore our choices are very limited. Therefore, very often we end up giving these patients 3 drugs, or you give 3 + 2 half drugs like azithromycin and linezolid, to make up for the 4th drug.
Okay, the last question I have before we close is a patient with, say, for example, this case where you have decompensated cirrhosis with tuberculosis. How does it change his transplant scenario? Say, for example, I have a patient who has now developed tuberculosis in the presence of decompensated ascites, and he is listed for transplant, or he wants to list for transplant. When do I list him for transplant?
So I think this is
transplant.
Because I actually have a similar patient at present. So his question is, when do I list? In presence of active tuberculosis, of course, transplant would be an issue.
So usually 4 weeks of ATT is good enough, and we have transplanted patients once they've received 4 weeks of ATT without any issues. And in an absolute emergency, we have even transplanted patients with active tuberculosis, where they were sputum AFB positive if it is acute liver failure. So that is again no longer a contraindication to doing transplants, but again this is a decision which the whole team has to take and understand the risks and benefits of doing a transplant.
Yeah, but his question, Dr. Lily, is a listing. So a listing can be done with active tuberculosis also. That's not an issue. As I rightly said, Dr. Akash Shukla, only if it is emergency, we have to go for tuberculosis, not a contraindication for the ALF, ATD-induced ALF. And for all cases of cirrhosis with tuberculosis, even every year we go for the 4 weeks of ATT. Whatever may be, it may be modified or maybe the full course as possible. And after 4 weeks of ATT, you can go for the transplant. I think this is a consensus. Okay, sir, I think we are going more than the time. We have to close at some point. So I request Professor Anand to give the closing remarks and vote of thanks.
I think it was a very good discussion, and there are a lot of interesting points that came up for discussion. And I'm sure this will help all the physicians who are in periphery to manage ascites more effectively. And I also picked up 1 or 2 more interesting points. Every time you listen to experts like Akash, and Vikas, of course, is an expert on ascites because he's done a thesis on this. So you always get additional information. God bless you all. It was a very interesting discussion, and thank you very much. See you again on 24th of June.
Thank you, sir.
Thank you very much.
Okay. Thank you. Bye.